I'm Jamie. I'm one of the F2s working at Guy's. I've currently 1 month into my community palliative care rotation, which is quite interesting, a little bit different. And I've been running this A to E series of lectures for the last three months or so. This is the 7th one. We've got one more to come in a couple of weeks, which will be on PR bleeding and hematemesis. So today we're talking about genitourinary stuff. Mainly it'll revolve around Haematuria and Dysuria, which are very common symptoms, very common signs that we see in the hospital setting. But we'll be using an A to E approach as always. So we'll just go through the A to E approach first of all, as we always do, just a little refresher, and then we will do some cases. I've got 4 cases today to go through. Hopefully it won't be too long. I'm aiming to go for about 45 minutes. Okay. So the A to E approach is really useful systematic approach. Some of you will now be final years. You will be getting close to doing your finals, and then you'll be doing your transition to F1 courses at various places around the country. After that, you'll be F1s on the ward, and it can be quite a scary place to start. And that's why it's really important to have a really good approach, particularly for unwell patients or patients that you might be worried about. It's used by all clinicians. Everyone knows the A to E approach, everyone appreciates it and thinks it's a really useful tool. And it helps you remain calm in difficult situations, and to gather control and a bit of understanding of what's going on. So be systematic, go in order of A to E, escalate early, particularly as an F1. Don't be doing this on your own. If you're worried, escalate. Someone will want to listen. And if they don't want to listen, find someone else, okay? And focus on communication as well. So not just amongst other medics who you may be working with, but the nursing staff also. It's really important to try and use everyone who's there if a patient is sick. So, oh, sorry, let me get the chat. Rachel saying, how can everyone else hear me? Rachel, you might just need to turn the volume up. Yeah, okay, perfect. So airway. This is the scariest thing that you might see, I think, is when you look at a patient and you think instantly their airway might be compromised, okay? So either they will have sort of snoring sounds, they might have like stridor, which is very similar to snoring sounds, or they might just have no breathing sounds at all. The airway might be silent, okay, and that's really worrying. And to sort of alleviate that, you can use maneuvers. So that can be a head tilt chin lift, or a jaw thrust. And you can also use airway adjuncts that we've got here. So the first one is a Goodell or an oropharyngeal adjunct, and it basically goes upside down in the mouth, and then you turn it over, and it forms a nice C with on top of your tongue. 2 is, oh, I think someone's got the mic on. 2 is a nasopharyngeal, which goes into the back of the nose, just like a nasogastric tube would, and is really useful, particularly in trauma settings, actually, when if there might be some craniofacial damage. But just remember that some quite common single best answer questions, a absolute contraindication for a nasopharyngeal is a basal skull fracture, okay? And then 3 down there is an eye gel, and commonly used by anaesthetists to get a more definitive airway. And then you can use an endotracheal tube, which is the best type of airway, because it has a cuff which you can inflate once you get past the vocal cords, and it prevents aspiration. All right. And then intubation, as I said, that will be with an endotracheal tube, but can also be with an eye gel there, number 3. And that's obviously done by anaesthetist. So if there's anything wrong with the airway, you need to put a peri-arrest out call, or fast bleep the anaesthetist, because they need to be there as soon as possible. So next one is breathing. So firstly, look at the patient from the end of the bed. How do they look? What are their SATs doing? What's their rest rate? So think about the observations, but then how is their general appearance? Do they look a bit blue? Do they look cyanosed? Is that central around the lips, or have they got peripheral cyanosis as well? Are they particularly tachypneic? Are they using lots of accessory muscles? So just get a general opinion of what you think their breathing is like, and then examine them. Have a listen at the front, but preferably at the back if you can, because you'll get a better listen to the lung bases there. Have a feel of the trachea, just to check there's no tracheal deviation. Look for expansion to make sure that it's bilateral, it's equal bilaterally, and then you can percuss as well. You're thinking about dull percussion, but also which would indicate an effusion or a hemothorax. And on the opposite side of the spectrum, if they're hyperresonant, that's more indicative of a pneumothorax, because there's air where you're percussing. If their SATs are low, get an ABG as a general rule of thumb, and get a chest X-ray. If they're unwell, make sure it's portable. You don't want a sick patient going down to X-ray if they don't have to. And then thinking about treatment. So with the adjuncts for airway, here with breathing, get some oxygen on them. If you're worried about them, just get a non-rebreathe mask on 15 liters to try and sort their hypoxia out. And then circulation. So again, look at the patient. How do they look? Do they look particularly clammy? Are they, what's their color? Are they very pale? Have they got really dry mucous membranes? Have they got a catheter in? And if so, have a look at the urine output. And then their OBS, like with breathing. So now we're thinking about the heart rate and blood pressure. So are they tachycardic? Are they hypotensive, which would be indicative of shock? And then examine them, feel the pulse, have a listen to their heart, what's their fluid status, which would include their cap refill time and looking at their mucous membranes, as I mentioned. And then get an ECG. Typically on any unwell patient, you should get an ECG as a rule of thumb. And then treatment. So if they are hypertensive, get a cannula in, as big a cannula as you can, 2 ideally if there's more people there. Take blood straight off it. And send bloods off depending on what you think might be going on. If you're not sure, just send them for everything. And then fluids. So you can give a bolus, so a fluid challenge of, if you're worried, 250 mils, but if they're young and fit, you can use 500 mils. And then think about further fluids beyond that if they're responsive to fluid. If they're not responding to a number of boluses, you might need to get ITU involved, because they may well need some inotropic support. And then D is disability. So I break that down into 4 things. So the first is their level of consciousness. So you can just simply use AVPU, whether they're alert, or are they responsive to voice only, pain only, or are they unresponsive. Or you can use a GCS score, which just gives a bit more detail. Check their BM, because quite often it can cause a lot of symptoms such as drowsiness that you might see. Check their pupils to check they haven't had an intracranial event, and then get a temperature on them to see if they're febrile or not. Remember, particularly old patients can be febrile if their temperatures, if they're hypothermic, that can still be a result of a fever, okay? And then finally, exposure. Typically have a good feel of that abdomen, and consider PRing them if you think that's necessary. Have a look at their skin. Are there any rashes or wounds that are looking a bit dodgy? Have they got any lines in that look a bit erythematous? And then have a think about whether you need to examine the neurovascular status of their limbs. At the end of the A to E, reassess, okay? Always reassess. If something changes, reassess, go back to A, okay? Because that'll be the most important thing to think about. And then look at what else is going on with the patient. Why are they there? What's their past medical history? What medications are they on? Any recent bloods or scans? What's their escalation status? Is there someone that's going to ITU or not? And then thinking about what investigations you've ordered and who's going to follow those up, particularly at the end of your shift, okay? Or if you're going into a weekend, who needs to follow them up, okay? So today we're doing, let me just go back. We're doing dysuria and haematuria, as well as a bit of testicular pain, okay? So they're, I've sort of bunched them together in urogenital type conditions because they can be emergencies, and patients can be very sick when they present with these. And there's a bit of overlap between all three of the symptoms, okay? So I will ask you guys in a minute about this one. So we've got a 75-year-old woman. She's on the general medical ward and she's got a bit of abdominal pain. She had a fall a couple of days ago, and that's why she's in hospital. She's got some pretty standard past medical history for an elderly patient. So you go and see her, and she's got abdominal pain. You start with your A2E assessment because you're not quite sure what's going on. Airway's fine. Her breathing's fine, although her respirate is a little bit up, okay? And she looks a bit tachypneic, and she looks a bit out of puff, but she's maintaining a SAT. So at that point, I think with SATs of 95, I think I'd probably just put her on a nasal cannula, 2 to 4 liters, just to get those SATs up. And then circulation, you ask the nurse to do some OBS, and she tells you that the blood pressure is 84 systolic and the heart rate is 112. And you are, with your examination while the nurse is getting those OBS, find that her cat refill time is 4 seconds, and the nurse reports that her urine output's been pretty poor over the last 4 hours. She's only produced 60 mils, okay? So at this point, I think we're worried about this patient. They are hypotensive and tachycardic. They are in shock and they are unstable, okay? So I think depending on your confidence, you would very much warrant putting out a peri-arrest here. I think that would be very reasonable, particularly as a newly qualified F1. But simply, you can just put if they got a cannula in, great. If they don't, put one in, take some bloods, and then give a fluid bolus of 250 mils. And more often than not, though, they will be responsive, and that blood pressure will go up to sort of 95, 100. And in that instance, you can give another one, just being wary of overloading them, okay? So while that fluid's running, you can carry on with your A to E. So disability, nothing much apart from you notice that she's quite febrile, 38.6, and her GCS is a bit low. Now, she's got Alzheimer's, so we don't know what's normal for her. You would presume that normal would be, maybe be 14 out of 15, because confusion counts for a point reduction. But 13, she might be a bit drowsy, only responsive to voice. So that's a bit unusual. And then when you examine her, you find that she's got some suprapubic tenderness. Okay. What do we think's going on here? Anyone got any ideas? Feel free to shout out. Yeah, excellent. So this patient has most likely has a UTI and is septic with that. I like that you've put urosepsis or UTI sepsis, fantastic. They could be in acute urinary retention, particularly with that reduced urine output, but they would be more stable if they're in urinary retention. You wouldn't expect that. It would go hand in hand with the suprapubic tenderness and the low urine output, but here we need to rule out sepsis. That's the most important thing, okay? And so then we're going to be doing sepsis 6. And once you've taken a history from the patient, she tells you she's got a bit of pain when passing urine, but that's all you can get from her because of her reduced GCS. So treatment, sepsis 6. I'm sure you've all seen this poster. Give oxygen, as we've already done. Give IV antibiotics, okay? Now, typically, the antibiotic you would give in a septic patient like this would be something like tazocin, but it's very much dependent on your trust. And lots, if you're suspecting a UTI, will add in another agent, quite often gentamicin. So just be wary of your trust protocols, or where to find your trust protocols so that you can look them up in an acute scenario, and give a fluid challenge as you're already doing, and keep an eye on that. Take blood cultures. So when you put the cannula in, take some blood cultures, and also get a lactate. She wasn't hypoxic, so a VBG is more than fine, just to give you a good mark of how septic this patient is. And then also, if anyone noticed, she had a long-term catheter. What should we do with that? Do we leave that in and use that to monitor the urine output, or should we change that? Yeah, good. So take it out, clean the area really thoroughly, and just pop a new one in. Because, as you're right, there may be an element that the catheter was blocked as well. So, but the likely thing that's happened here is that she's got a catheter-associated UTI, and that's causing urosepsis. All right, good. Next case. You are bleeped by a nurse to see a 72-year-old man on the urology ward who has a background of bladder cancer. So the nurse states that his urine has become particularly bloody, which is a little bit concerning. So you go and see this man, and from the end of the bed, he is in agony. He's screaming out in pain. He's writhing all over the place, and he cannot get comfortable. So again, A to E, his airway is fine. Trachea central, his airway's patent. His breathing is okay, but again, as with the last case, he's a bit tachypneic. His respirator is 21. So, you know, you're just a bit concerned about him, but most likely cause of that is his pain. On circulation, his blood pressure's fine and his heart rate's a little bit high, but we're not really worried about that. Again, cat refill time's 3 seconds. So he's a bit dry, and there's no cause for major concern, but we just want to keep an eye on that. Disability is fine. There's no problems there. And you move on to exposure, and you see, as stated before, he's in severe pain, and he's got a 2-way catheter in, and in the catheter bag there's dark red blood with some clots. When you feel his abdomen, he's got really bad suprapubic tenderness. Okay. So what does this guy need? Think about stabilizing the patient first. Yeah, antibiotics. Okay. So he's afebrile, so I'm not sure that he does need antibiotics at this moment in time. I don't think he's septic. But yes, I agree. He definitely needs fluid. So he needs a cannula in with some fluids running, probably a bolus actually. It might just make him feel a bit better. And some analgesia. Yes. So this man is, when you get a patient with clots in their catheter bag and they're screaming in pain, the most likely thing is they are in clot retention. So yes, you need to unblock the catheter. But thinking about that comes in a little bit. Thinking about the A to E approach, the most important thing for this man is he's a little bit tachycardic and he's a little bit hypotensive. He needs bloods and he needs a blood gas. Okay, the blood gas will give you an idea of his hemoglobin, but they're not always the most accurate. So you need a formal full blood count as well. And alongside that, you need to send a clotting, as well as standard UNEs, just to check his renal function, because his renal function might be deranged if he's been in retention for a while. But also a group and save, that's really important, because he may well need blood if he's losing a lot of blood, because you don't know what his hemoglobin is at this point. Can I explain why he needs blood gas? Yeah. So as a rule of thumb, sorry, most sick patients need blood gases, mainly to see what their lactate is, but also just to have a look at their bicarb as well. And in this situation, a blood gas gives you a hemoglobin. Now, it's not a gospel reading, it's not really accurate, but it gives you a marker. So if someone's hemoglobin sort of 82 on a gas, it can be anywhere between sort of 70 and 90. That's the rough plus or minus 10, so it's not completely accurate. But it just makes you aware of how unwell this patient is. And, you could see his gas and his hemoglobin could be 40, and then you think, actually, this is really bad. We might need to put a sort of a major hemorrhage protocol out. Okay. Fine. So let's say his hemoglobin on the gas is 90, and you've sent some bloods off. You don't think he needs it urgently, but you've sent a group and save, and you might cross match a couple of units just to be sure. So then what else do we do? So first of all, think about why he's bleeding. It's probably going to be the bladder cancer that's causing blood in his urine, causing his hematuria. But there are a number of causes. People can have subsequent prostate cancers as well. He may have had radiation in the past and have a radiation cystitis, which is causing it. He may have a completely unrelated cause for his hematuria. So just be aware of that. Stabilize the patient, as we've done, as we've spoken about. And then the treatment of clot retention. So someone said it perfectly, flush it and unblock the catheter. And I completely agree with that. And you can, particularly if you're inexperienced and you're not really sure about what to do, just get a syringe, 20 mils of saline in a syringe, and put it through the catheter, and it should just unblock it. But it probably won't work, and it might just cause them a bit more discomfort. So really the best thing to do is speak to urology, and they'll probably ask you to take the two-way catheter out and put a three-way catheter in. And I've put a picture of one here. Now, a three-way catheter is important because, first of all, it tends to have a bigger lumen, so it's going to be less likely to go into, or for clots to build up within the catheter. But the third lumen that you see there on the drawing is, if you can see my mouse, that one there, that allows you to irrigate, as someone has said there, to irrigate the bladder, which is a really, really useful tool. So first of all, you wash it out, so wash it out, as I said, with saline. Really wash it out till you can till you can see no more clots coming out. It'll be like a rosé color, and that's going to be really painful for the patient. So we can give analgesia, and I'll talk about that in a minute. But once you've got rid of the clots, they need to be on irrigation, because as soon as the irrigation stops or the washout stops, they're likely going to start bleeding again, and the clots will redevelop and they'll go into retention again. So for that, you can connect massive sort of 4-liter bags of saline that go straight into that third port, and wash the bladder out continuously, and that then drains through the normal port in the middle there. Now, someone's mentioned a suprapubic catheter. Yes, absolutely. And but you wouldn't be doing that on the ward. So a suprapubic catheter is like a procedure that you would do in CPOD, in the emergency theatres. And it's only if this fails. So if they keep going into clot retention, or their catheter keeps blocking, you can think about doing a suprapubic catheter. And then analgesia is what I was going to speak about. So analgesia, you can obviously go up the pain ladder, and paracetamol, then codeine, then Oromorph is typically what it is in an acute scenario. With this, I would probably go straight for Oromorph, but the chances are it's not really even going to, it won't touch the sides if they're in clot retention. So this is one of the only times that I would give either IV morphine or subcut morphine, okay, and start with a very, very low dose, but it's a really, really effective painkiller, and these patients are in absolute agony, and then you give them some IV morphine, and sort of a couple of minutes later they're much, much more comfortable. So it's really, really effective, but you just need to be wary of giving IV morphine, because it's a dangerous drug. And then, so yeah, that's clot retention. It's good about hematuria and the causes of it, be that malignancy or treatment for malignancy, or infections or stones. Okay. Any questions, guys? Pop them in the chat, and I will endeavour to answer them. Okay. So case number 3. I'm just going to grab another drink. So you're asked to clerk a young lad on the general surgical shift. So he's bypassed A&E and you're seeing him straight away. And he's coming with testicular pain. Okay. Are we worried or not worried without looking at the A to E? Young guy with testicular pain. Worried? Yeah, very good. Well done. Fine. So we'll just rush through the A to E because there's not a lot here. Airway's fine. His breathing's fine. He's not tachypneic. For a 14-year-old, those the blood pressure and heart rate is not particularly concerning. He's not underfilled. Disability is no concern, and his abdomen is soft, non-tender, with bowel sounds present. Are there different ways hematuria can present that we should be aware of? Yeah, absolutely. And so you can get patients report like a tiny specks of blood in their urine, and that's more indicative of something that would cause minimal bleeding. So like a small stone somewhere in the ureter or the kidney might cause that. Whereas someone presenting with like frank blood in their urine that is that has lots of clots in it, that's going to be a big site of bleeding. Okay, so that's going to be a tumor that's bleeding or a vessel that's gone. Okay, so that does help, but often there's a middle ground where you've got sort of dark rosé urine and you're not quite sure about what the cause is, particularly if you've got no background to the patient. Okay, so just going back to this, I hope that answered your question. Just going back to this one then, testicular pain, what's the first thing that comes to mind? which is why we're worried. Yeah, fantastic. Torsion. Okay, torsion is really, really worrying. And anyone know how long from onset of torsion to being or how long it takes basically for the testicle to die? 6 hours. Fantastic. Good. 6 hours is the figure in everyone's head. Good. Yeah, so that's why it's worrying. It's no joke, and they need urgent help. But the first thing you need to do, so they're hemodynamically stable. Excellent. Now you need to do a testicular exam, okay? And it might not be something you've practiced before, or you might have done it. Maybe you've done it as a med student, and it was someone that had a hernia or something like that. But it's a really important examination to just try and rule out other causes really, and find out whether this is a genuine torsion that needs to be taken to theatre. So look at the testicle. How does it look? Is it erythematous around it, around one of the testicles? Is one of the testicles, has it been pulled up into the body, which would indicate torsion on that side? And then have a feel, is the testicle itself really tender? Okay, because that also would lead you to believe that this is a torsion. And the last thing I do for testicular examinations is transillumination. So just shine a light through the testis. And this is really useful for seeing, for ruling out whether there's fluid that's causing this pain, okay? Particularly if it's a bit of a dull ache rather than a really sharp pain that had a sudden onset. So if there's fluid in, it will transilluminate, and that would be more indicative of a hydrocele, okay? But also think about the histories, go through your Socrates. Is it sudden onset? Was it during some sort of trauma or during some sort of sport, and then suddenly they had this real onset of pain that has not gone away? That's typical for a torsion. When you're doing it, it'll often be in young people, but quite often teenagers, or 20 to 30-year-olds. So make sure you have a chaperone, as you should with any patient who you're examining genitalia. And that shouldn't just be a relative, that needs to be a healthcare professional. The most likely diagnosis we've spoken about, which is torsion, but other testicular pathologies, that he could have a torted appendage of the testicle, which is as serious, or it could be a cyst of Morgagni, which is a sort of embryological remnant. bit of a red herring, or it could be a hydrocele or a fluid buildup secondary to an epididymoorchitis, which is an infection of the testicles. So investigations. So say this is a dull ache and the history is not quite perfect for a torsion, and you're a bit cautious and you've got a bit of time to play with. They've come in straight away. What investigation could we do for this patient rather than taking them straight to theatre? Yeah, excellent, ultrasound. And what are we looking for in an ultrasound? Does anyone know? Two things, really. So you're looking for fluid that can be a cause of a hydrocele, or you can be looking for any masses, cysts as such. You can look for a torsion itself, but it's not brilliant, a bit like appendicitis, as ultrasounds aren't brilliant for that. So if you're thinking more an epididymoorchitis, what would your treatment be? Anyone know? Yeah, antibiotics. And the guidelines different. At my old trust, it was quite interesting. It was for patients over 35, you treated it as sort of, they got it from a UTI. So you treat basically for E. coli. In patient under 35, it's more likely going to be an STI. So you need to send off sort of gum screens and think about tapering your antibiotics to match that. Okay, but as a barn door rule, if a patient has sudden onset testicular pain, they need to go to theatre. Most important thing for you to remember when you're clerking them is flagging it up early to the registrar so that they can book them in. Making sure they're nil by mouth, that's probably the most important thing, and then sending bloods off, including a clotting and a group and save, because obviously they're going to theatre. Okay, in tertiary centres it will be urology that does the procedures, but in a lot of DGHs the general surgeons do the torsion cases. Okay, so that's torsion. How are we doing for time? Yeah, not too bad. Fine, we've got one more case to go, guys. Again, any questions, please do just pop them in there. I'll try and answer them. Let me just try and remember what this one is. So we've got a 43-year-old woman. Oh dear, and I put his, apologies for that. And they report that they've had some blood in their urine and they've got some right-sided abdominal pain. And you've been asked to go and clot them in straight from A&E on the medical take. Oh, someone's put something in the... So, oh dear, that's given it away. Apologies, everybody. So the airway is patent, trachea is central, their breathing's fine, but their respirator's a bit up. And they're actually looking quite a lot of discomfort, which is probably why they're tachypneic. Their hemodynamics is stable, although they are slightly tachycardic, and they're not underfilled. Disability is fine. And then on exposure, you find they've got some right-sided abdominal tenderness and some pain affecting the right flank. Now, what diagnosis have we done? Have we got here? Stone, number one, I completely agree with that. Sharp pain, hematuria, right flank pain, often goes loin to groin. Yes, good. Other differentials, kidney reasons. So yes, you could have like a pyelonephritis. That's very, very true. It would cause the same pain. They'd probably be febrile though, and they might well be a bit more unwell if they had pyelonephritis, but can definitely happen, and you can definitely get a bit of hematuria with it. Any others? Could it be cancer? Yes, could be. Could be a renal malignancy. With that pain, you'd want to feel for any masses there. Yes, excellent. This is what I wanted to get onto. Infection. So I'm thinking mainly about sort of pelvic inflammatory disease here. It can cause a bit of hematuria, and ectopic pregnancies as well. Yes, because in this age, it's very important to do a pregnancy test because they've got abdominal pain. That's just barn door. If they've got abdo pain, do a pregnancy test. But the hematuria, they've told you they've got hematuria, and they're probably correct, but there is a chance that they might have mistaken it for PV bleeding. Okay, so yeah, ectopic and just gynae pathology in general is really important. So for that reason, you could consider doing an ultrasound. But if you think they've got right flank pain, they've got hematuria, they may well have a past history of stones, then the first investigation is what would we do first? Ultrasound from one person. What's the most appropriate? Yeah, I think a CTKUB is the most appropriate. Okay, CTKUB is the gold standard for renal stones. All right. If in an exam question, if it says they've got hematuria, they've got hematuria. They won't try and trick you like that. Okay. If it was PV bleeding, completely agree. This person needs an ultrasound, and they need workup for that. But if it's genuine hematuria and they've got flank pain, then a CTKUB is good. And is that with or without contrast? Anyone? All gone quiet. Can everyone still hear me? Without? Oh, excellent. Sorry. Yeah, perfect. Yeah, without, definitely. Because the chances are the stone's going to be radio opaque, so you'll be able to see it. If you gave them a CTKB with contrast, you wouldn't be able to see a thing. All right. So you also want to do a urine dip just to check there's hematuria in there. That's very good. Or have a look at it, obviously. And get a send an MCS off, because often Stones patients will need antibiotics, particularly if they've got some hydronephrosis, because basically stagnant urine can lead to a buildup of bacteria, and it can cause sepsis quite commonly. Excuse me. And then treatment. What do we do? And it's all dependent on the stone size, and I'm not going to go into it in too much detail. But if they're small, sort of 2 to 3 millimeters, you can just MCS. Sorry, urine MCS. So it's microscopy culture and sensitivity. So you basically get a pot of urine, send it off to the lab, and they grow what they can. So, and then they look under it, the microscope. They culture it, obviously, and then they test different antibiotics on it to see what it's sensitive to and whether it's resistant to any antibiotics, which is really, really useful to know to make sure you're treating with the right antibiotics. So if they're small, you can just watch and wait and hope they pass it. And yeah, that's with supportive treatment. So that's mainly analgesia and some fluids. Okay. Just try and make sure they don't get dehydrated. Check that they're not in check there's no hydronephrosis. And the CTKUB will show that, but you could use an ultrasound as well. And then you can do extracorporeal shockwave lithotripsy. You basically zap them with ultrasound, zap the stone, break it up into fragments, and it'll pass. But that can be quite painful. So again, make sure they've got adequate analgesia prescribed, both on the regular and the PRN side. And ureteroscopy, you can go retrograde. So use a cystoscope to go up into the bladder and then the ureters, and basically hoover the stone up. Or if it's a big one, and this is what's used for staghorn calculi, the big ones in the kidneys, you can do percutaneous nephrolithotomy, where you basically it's an IR procedure, interventional radiology, and you basically go in adjacent to the kidney and break the stone up like that. Okay. Little bonus question: what's the best analgesia for renal colic? Radio silence again. Oh, here they come. Excellent. Yeah, very good, everybody. It's PR diclofenac. So diclofenac's an anti-inflammatory, but it works best PR for renal colic, which is really interesting, and good as well because you don't get the GI side effects that you have from giving it orally. And I think you can have 150 milligrams as a total in a day. So some people give 100 milligrams PRN, some people give sort of 50 milligrams TDS, or 3 times a day, sorry. So that is that. Excellent. Someone asked on the Q&A chat, so I've only just seen it. What's the role of the chromosteric reflex and Prenz sign, in distinguishing testicular pathology? And to be honest, it's a bit of a tricky one. And from my experience in my last job, they're rarely used, and they're more academic than anything, and actually a good history and a good clinical examination, as well as potentially an ultrasound, will give you the best diagnosis. Okay. So I think that is it.